a pleasure to address a distinguished audience of colleagues. And I'm a pharmacist by background. I started my training in infection about 20 years ago, and I've still got the bug, as they say, but always throughout my career worked very closely with nursing colleagues and allied health professionals and doctors, and we're all in this together. I think we're all affected by antimicrobial resistance, and we're all in this fight against infection and avoiding infection, so thank you for your efforts. This just provides an overview of what I'd like to talk about, but really I'd like to just offer you reassurance that NHS England takes infection and takes antimicrobial resistance very seriously. It has made a commitment and invested in resources to try and tackle AMR, and Professor Avery has mentioned many of those already, and hopefully you'll be feeling, as a taxpayer, as a citizen, reassured that the government, the health service, the Department of Health, we are working hard to try and protect the population, protect you and your families from the harm of antimicrobial resistance. And secondly, my other aim is to recruit you to the cause again. I know many of you are already embedded in the cause, but please feel free to engage with colleagues working on antimicrobial stewardship in whatever organisation you work in, and join the effort, join the crusade against resistance. Now this slide, many of you will be familiar with this, published in the Lancet ID just over a year ago, and it was the first of its kind, a global study of the burden of infection and antimicrobial resistance. And of course the headline shocking statistic was that every year 5 million people die of infection caused by antimicrobial resistant organisms. So AMR is associated with 5 million deaths, and it's thought to be the direct cause of death for just over 1.25 million people every year. And this work being done by the Graham collaborators based in Oxford in the UK is now being extended to look at the economic consequences of AMR, because we all need to be able to make that case for investment of resources and equipment, staffing to try and tackle AMR, and understanding the economic consequences of AMR. So the Graham project also allows, it provides an interactive website. I'd encourage you to look at it. The link is on the bottom of the slide here, but it allows you to drill down to one country, and in our case, of course, we're interested in the UK, and in the UK, the number of patients dying of sepsis is just over 110,000 people per year, so this is deaths from sepsis. About 90,000 of those are caused by bacterial infection, and 7,500 deaths are directly caused by antibiotic-resistant bacteria. You can see from the slide that respiratory tract infection is the main cause of death, as well as sepsis, and looking across to the right, you'll see you can put that into context with deaths from meningitis, deaths from TB, so you can see the burden of respiratory tract infection there. So within NHS England, within government, the Department of Health, we are mindful of the mandate that's been set in policy, and most importantly for us is the UK National Action Plan for tackling antimicrobial resistance. The World Health Organization invited countries to develop national action plans, and the UK's was one of the first, and we're now on to our second 5-year national action plan. We've just entered the final year of that plan, and we're beginning to draft with infection prevention colleagues the next national action plan. But from a prescribing perspective, there are two major ambitions in the current national action plan, and they are for community prescribing of antibiotics to be reduced by 25% from the year 2013, and within hospitals to reduce the use of the more valuable antibiotics in the watch and reserve categories as defined by WHO. So these are drugs that tend to be reserved for second or third line use, to reduce those by 10% from 2017. Within the NHS, the long-term plan carries a section on antimicrobial resistance and includes a commitment that the NHS will support the goals of the UK AMR National Action Plan. Some of those being that we will continue to optimise the use of antibiotics and reduce the unnecessary use of antibiotics, allow and improve access to both old and new antibiotics, and ensure that we have appropriate access to diagnostics and digital systems such as e-prescribing systems to try and support the best use of antibiotics. And obviously important at the current time is, as we are integrating primary and secondary care through integrated care systems, working to deliver system-wide improvements on the use of antimicrobials, appropriate use. And then NHS England, or the NHS, is committed to providing resources to and clinical expertise to lead on efforts to tackle antimicrobial resistance. And I think that's testament to that is the fact that our National Medical Director in NHS England, Professor Sir Steve Powis, is the Senior Responsible Officer for Antimicrobial Resistance. That's how seriously NHS England takes this, and Professor Powis chairs our Antimicrobial Resistance Programme Board every quarter in NHS England. So how are we doing? Unfortunately, not terribly well against these national ambitions. So the chart on the left is our data from an open access website called Prescribing, and the orange line represents total antibiotic prescriptions dispensed every month in the UK for the last 5 years. And you can see, with the eye of faith, there was a gradual downward trend, which is the case. But then in December last year, we experienced an outbreak, as you know, of Group A strep, an invasive Group A strep infection, and that coincided with a surge in prescribing of antibiotics. And prescribing doubled, almost tripled, based upon typical December prescribing patterns. So that has been a setback in terms of trying to reach these ambitions set out in the National Action Plan. So I would call on you all we need to redouble our efforts for the final year of the National Action Plan and try and support colleagues and clinicians with prescribing fewer antibiotics where it's safe to do so. On the right-hand side, these are data from the NHS Oversight Framework and show that the increase in prescribing in December has resulted in a slight increase in the annual data, and so we're still quite far off meeting the goals of the National Action Plan. And then from the hospital secondary care perspective, I mentioned that the WHO has defined different categories of antibiotics, including access, which are the most narrow spectrum first-line agents, and then watch and reserve are the groups that we've been invited to encourage to reduce the use of by 10%. So on the left-hand side here, we have a chart from Fingertips from UKHSA colleagues, and I've chosen one hospital to report here, but the black dots represent the England performance, and you can see over time that these are data for defined daily doses of watch and reserve, so treatment days of watch and reserve antibiotics, and you can see that line is pretty flat over the last few years, so haven't seen much change in the use of these agents. And that's in contrast to what's happened in Scotland, where the green line there from the Scottish SONAR report demonstrates that the use of watch and reserve antibiotics in Scottish hospitals has decreased by 21% from 2017. So Scotland has achieved that reduction, a 21% reduction, far in excess of the target of 10%. So it is possible, and we're hoping that a number of initiatives that we're introducing this year might bring us home by the end of the fifth year of this National Action Plan. So what has NHS England done in terms of investing in antimicrobial stewardship? Well, we've appointed a team, and I was fortunate enough to be appointed to lead this team. Many of you will be familiar with some of these names and faces. So each of the 7 regions of England, as defined by NHS England, has a regional lead now for antimicrobial stewardship. And in most of the regions, they're supported by a part-time project officer. And then within the national team, I have support from colleagues with project management and with translation of research into practice. One of the first things we needed to do as a team was define our strategic objectives and prioritize what we needed to work on in the first 2 or 3 years. But ultimately, we were all in agreement that our absolute top priority is to improve clinical outcomes for patients, improve the care of patients with infection, the quality of their care, and reduce morbidity and mortality. And where safe and appropriate, to reduce exposure to antimicrobials, which would therefore reduce antimicrobial resistance, but also, and as Professor Avery mentioned, reduce waste, unnecessary use of medicines, and reduce the carbon footprint of medicines. So our first major objective is to optimize infection management, and that can be a combination of improving the investigation and diagnosis of infection, controlling the source of infection where that's important, ensuring that infection is treated promptly for patients with sepsis, but using delayed or backup prescriptions where that's safe and also appropriate. And then making sure that the clinicians choose the most effective treatments, using the right route of administration and the correct dose. And finally, and most important for hospitals, to ensure that prescriptions are reviewed after 2 or 3 days when results become available to streamline and target that prescription appropriately. And so there are a number of tools at our disposal that we can use to achieve these goals, and I'll talk a bit more about them in a moment. The second major strategic objective is reducing demand for antimicrobials. Now that can be demand from clinical need, so the incidence of infection, the burden of infection, but it can also be demand from patients and patient expectation. And so clinical demand could be reduced, for example, by improving vaccination, by public health initiatives and awareness and training, and infection prevention and control, of course. And patient empowerment is something that we feel very strongly about, that we'd really like our families, our friends, citizens of the country to feel more capable of managing their own, certainly minor illnesses, but recognizing when an illness is more serious that they need to seek help from a health professional. And then finally, the third strategic objective is to reduce exposure to antimicrobials. And that means reducing overprescribing, but doing that safely, encouraging use of the shortest effective treatment courses so that we don't drive resistance unnecessarily, and then encouraging the use of the narrowest spectrum antibiotics to avoid collateral damage to normal microbiota and avoiding selecting opportunistic infections like C. difficile. And this can be achieved through some tools such as risk scoring tools for patients and clinicians, and the use of diagnostic tests, and increasingly point-of-care diagnostic tests. Now, we've identified 7 key enablers that will support these strategic aims, and we've used behavior theory and behavior change science to try and structure these enablers. Some of you will be familiar with this model of behavior change proposed by Professor Susan Mickey at University College London, called the COM-B model. And this proposes that human behavior can be dictated by or predicted by the capability of an individual to perform a behavior, the opportunity that they have within their environment, and in our case within their working environment to perform a behavior, and their motivation to perform that behavior or not. So under capability, we grouped public and patient empowerment and building the capacity and capability of our workforce. As far as motivation is concerned, we have the tools of policy and commissioning at our disposal, and we have a role in NHS England of supportive oversight and holding to account and looking at performance. And then under the opportunity banner, we are promoting the mobilization of knowledge so that clinicians have information they need at the point of care to make the right decisions, of using data, using it intelligently to drive improvement, helpful data for people that allows them to identify if they're an outlier and to track their performance. And then finally, to take advantage of digital and medical technology where that's appropriate and helpful. So I'd just like to give you a flavor of some of the work we've been doing so far since the team was established last year. So Professor Avery mentioned that community pharmacies have become very engaged in this initiative to promote antimicrobial stewardship, and we provide resources in collaboration with colleagues in the UK Health Security Agency and the RCGP through the Target website. We have resources for community pharmacy to support with counselling patients who present with a prescription for an antibiotic or who present with symptoms of an infection. And on the right-hand side there is an example of a resource that we're developing for staff working in GP practices and primary care networks who are inviting patients with recurrent infections to attend for a review, and helping those staff to work through how to prevent infection in those patients who are really suffering with, as Tony mentioned, sometimes 10 or more incidents of infection every year, and exposed to multiple courses of antibiotics and inevitably becoming infected and colonized with resistant organisms. So it's how staff can support those patients to avoid infection, reduce the incidence of infection, and reduce the need for antimicrobials. As far as workforce is concerned, we carried out a survey in collaboration with our colleagues in infection prevention and control last year to understand who is working in antimicrobial stewardship and how much time have they got. And it wasn't just limited to pharmacy. This was a multi-professional survey, and I've just presented some of the results here for pharmacy professionals, but it illustrates quite a bit of variation both in secondary care and primary care. And clearly we now need to understand what's the impact of that variation and how many staff is the right number of staff and what training should they have to make them effective. In terms of knowledge mobilisation, we've instituted a monthly evidence review, a journal scan, and we publish a bulletin which is accessible to any of you on the future NHS workspace, the AMR Programme workspace. And we published our first evidence bundle for the delabelling of patients with penicillin allergy labels. And we worked with UKHSA again to develop a national criteria for switching adult patients from intravenous to oral antibiotics. And one of our team, Conor Jameson, will be presenting here tomorrow in more detail on that work. Data-driven improvement, this is exemplified by the AMR dashboard, as Tony mentioned, which is available through the Foundry system. And the chart on the left just illustrates how we can map geographically where resistance is a big problem. In this case, it's E. coli bloodstream infections resistant to co-amoxiclav. And this sort of information helps us to write local treatment guidelines so that first-line treatment choices are going to be effective. And the chart on the right is taken from Model Health System, which is accessible to very senior leaders in ICBs and hospitals. And this one illustrates admission to hospital with urinary tract infection and how that varies across different ICBs. So there's clearly some opportunities for learning and sharing that learning with other systems. And this just screenshot illustrates where AMR sits within the policy priorities section of Model Health System. So it's been given very high priority. To take advantage of the digital systems that are increasingly being used in primary care and in hospitals, we have been working to develop what we call a digital vision, so we've been interviewing clinicians of all professions who work with digital systems in primary care and secondary care to ask them, how are these systems helping you at the moment to prescribe antibiotics appropriately? What could they do better? And we will ultimately come up with a description of what good looks like for these systems and present that to the software developers and say, this is what NHS England would like to commission from you. Is this functionality that colleagues on the front line find genuinely helpful? And it won't be nagging alerts that keep popping up. It'll be hopefully more clever and helpful digital functionality. I mentioned the intravenous to oral switch, and Tony's mentioned that we have a CQUIN, which is stands for Commissioning for Quality and Innovation. We have a CQUIN for hospitals this year to promote the timely, appropriate switch of intravenous antibiotics to oral. And there are so many reasons to do this, for patient benefit, but also for the benefit of health staff, and importantly to release nursing time, which we know that it takes from a time and motion study in Birmingham last year, published this year, that it takes 22 minutes on average for a member of nursing staff to prepare and administer an intravenous dose in comparison to 2 minutes for an oral dose. So every dose that can be reduced is time that's released for nursing staff to be able to do their jobs and to do it to reduce the pressure on them and to allow them to perform the tasks that they would like to do in their healthcare environments. Tony mentioned a focus on course length. So these data, in terms of supportive oversight, we share data within regions to try and encourage organisations to benchmark, to identify if they're an outlier for performance, identify where they might be able to improve and how to focus their efforts on improvement. And course length is one example. So this chart is of amoxicillin prescriptions in primary care, amoxicillin capsules. NICE guidelines recommend 5-day courses for every respiratory tract infection except for, I think it's exacerbations of bronchiectasis. So 5-day courses should be the norm, but the dark blue bars show where their 7-day courses are prescribed, and you can see variation across the different integrated care boards. This is in the east of England, but you can see encouragingly there's improvement year on year, and we want to further improve and move that light blue bar for 5-day courses up to close to 80 to 90%. So just an example of how data can be really powerful and used in the right way. And Tony's already been through this slide in detail, but it's reassuring to see how much alignment there is between antimicrobial stewardship and the overprescribing review and the work that's going on to tackle overprescribing in general for medicines in general. And we share many of the same priorities and using the same levers and promoting the same messages. That I should mention just the carbon footprint message, that intravenous antimicrobials in many cases can carry a very heavy carbon footprint, which won't surprise you when you consider the plastic that goes into intravenous medicines, the bulk, their manufacture, their transport, the giving sets, the fluids, In the case of ciprofloxacin, one antibiotic, for example, ciprofloxacin's carbon footprint is estimated to be 70 times that of oral ciprofloxacin tablets. So early switch, timely, appropriate early switch to oral antibiotics will hopefully play a role in reducing the carbon footprint of the NHS. And finally, last but not least, and my colleague Esther from the AMR programme and our infection prevention team will talk more about this, but all of you in this room, many of you are nurses and play a hugely important role in antimicrobial stewardship, and I'd just like to say thank you and to appeal to you to keep up the good work and continue to be a champion for antimicrobial stewardship, as well as all of the great work you do on infection prevention and control. So hopefully you'll agree that we've made some solid progress so far, but there's always more to do when it comes to AMR. It's not going away. NHS England has appointed this team to lead on antimicrobial stewardship. We have identified our strategic aims and those key enablers, and our work is aligned to the work of the National Overprescribing Review. We are using Future NHS as a really valuable resource to host many of our information and tools. So please do, I would encourage you all to, if you're not already registered with the AMR programme workspace, please do so. Anyone with an NHS or public health email address can register. And we're always listening and we're always looking to improve. So if you've got suggestions, if you think we're missing something or we should be prioritising something else, then please drop us a line. And I'll look forward to answering questions later. But I'm going to hand you over now to Esther. Thank you all very much.